Hi, welcome to Facebook Live. And as usual, I'm Annette Mercatante from the St. Clair County Health Department. And we have Justin.
And I'm Justin Westmiller, the Director for Homeland Security and Emergency Management for St. Clair County.
Okay, so thanks for joining us. Let's get right to the data, shall we? And we'll go over that real quick and then get right to your questions. So we are very close to our 4,000 mark. We should be there by tomorrow, since we're adding an average of about 100 cases per day for the last several weeks. So we'll be close to we'll be over 4,000, I'm sure, by tomorrow. A total of 240 hospitalized patients and 77 deaths, with a few more deaths coming down the pipeline, I think, as well. So we also have a lot of recoveries, as you know, and as I mentioned to you last week, do be cautious with the absolute numbers of recoveries, because removing those recovered from our system has been a little bit labor intensive, and we're a little bit behind those. So probably more people than this have recovered. In general, though, we have in the last week over 700 new cases. I mentioned over 100 new cases per day on average. And we're doing a little bit more robust testing. We're up in the 900 range of testing, with an ongoing positivity rate of 16.5%. Next slide. So that's our curve. It looks a lot like the rest of the country, and certainly of Michigan. Of note, you might notice at the top of that curve, if you look very carefully, you could maybe consider that a little bit of a flattening. It's too soon to tell, but we certainly are hoping that we are reaching the peak of this current surge. We'll see. And then this is just our ongoing cumulative testing total. You can see our cumulative testing positivity is going up in reflection of what we're reporting on an average daily basis of the 16%, but the cumulative is also going up. And there's our data dashboard, which you can see the day-to-day data changes as we go along. So I'll also just report really briefly on our hospital system. We have all of our hospitals are reporting that they are not at peak capacity, anywhere from 70 to 80% of their total capacity. As I mentioned before, capacity is a fluid number. Our hospitals can expand their hospital beds, and all have plans to expand if needed for extra capacity. And hospital capacity is also relative to their staffing ability. So that is not a finite or concrete number, but they are reporting still the ability to grow. And then we have about a 23 to 24% of our hospitalized cases are COVID related, which is obviously higher than what we were seeing last month. Our ERs are reporting being busy, but not overwhelmed. And we continue to monitor that situation closely. So let's get to the questions.
Okay, you ready?
Go ahead.
Okay, first question. These came in last night. We are about 1 week into the scale back or shutdown, and the numbers are still high, if not higher. Then add in Thanksgiving. Do you really think you'll see a decline in cases by December 8th?
Well, we hope so. We hope that more people do the right thing than don't. We do know that there's a lot of risk of exposure and transmission as people get together. But we're also hoping that most people understand the importance of the short-term sacrifices for the long-term gain. So we are still seeing increasing numbers, but as I mentioned on our flow chart, our graph, that we are hoping to see some slowing of that. And I'm going to remain cautiously optimistic, but we'll be able to tell you a lot more after next week.
Okay, thank you. Justin, this next one is for you. Are igloos allowable for dine-in services under the MDHHS epidemic orders?
So igloos are allowable, and here's why. Usually they're singular families or very small groups, and under the guidance that we've been provided, they are allowable to be used by the restaurants in our area.
But please just put one family in. The idea is just one household is in the igloo, not you're not putting a bunch of people together.
Yeah, now's not the time to go out and have a dinner party with a bunch of different groups of people at the
Just
same
because
time.
the igloos are still open, right? Yeah.
Right.
All right. This has been a pretty common question. It's about the data. There's several questions in one. What is the age range of deaths in St. Clair County? Can you also tell us what underlying conditions they had? Also, age range and underlying condition information for those hospitalized. I believe you have those
Sure.
right in front of you.
So we've answered this question a few times. I mean, the range kind of follows the national averages. There's nothing unique about the people in St. Clair County who get sick and who dies. But the general, we have a average age of 73, but the range for hospitalized individuals is anywhere from early 30s up into the late 90s. So wide range, although the average is 73 years of age. Excuse me, that's deaths. That's deaths. My apologies. As far as hospitalizations, the range is 3 months to 90 years. And I don't know, that average would obviously be very skewed because of that broad range. So again, people can be hospitalized often because there's over other conditions, but in 5% of our deaths, there is no other reportable comorbidity. And we also know that St. Clair County has a fairly high representation of chronic diseases. And we know that through our community health needs assessment. We have about a 60% of our population obese or overweight, which is a known risk factor. We have higher than average rates of respiratory illness, which is a known risk factor. And so if the intention of that question is to suggest that, well, if I don't have these comorbidities, or if I'm not in this age group, I don't have to worry, that is really not the case. Because I would say between one risk factor or another, almost everybody is probably has something in their history that may make them susceptible to more serious illness. You just can't predict a serious illness with this virus based on what we know at this point in time.
Okay, thank you. Justin, this one's for you. How are we doing on supplies? And does the county have enough PPE for this increase in cases that we're seeing?
So supplies wise, we're doing okay. I'm not gonna say that everything is readily available and we can just get it whenever we need it. There are some things that we are running short on. The highest of that is medical gloves, latex gloves. We know that those nationally are in a shortage, and we're feeling those effects here in St. Clair County. We, to date, have been able to get everything we've asked for from the state. Sometimes we just don't get quite the numbers we've asked for, but everybody's working together to make sure we meet the logistical and supply challenges of this ongoing response, and we expect to endure with our supplies.
Okay, thank you. All right, the next question. How long after someone stops having fevers do they still need to quarantine?
Well, that's kind of a convoluted question. Let's go over definitions again. Isolation is when you exclude yourself from other people and don't expose yourself to other people when you're sick. A quarantine is when you exclude yourself from other people when you've been exposed, but you're not ill. You might become ill because we know you've been exposed. So we have you wait a certain period of time to make sure that that virus doesn't incubate and become infectious in you. So quarantine is when you're exposed and not ill, and that is 14 days from the last day you had an exposure. That's how long you have to wait to safely assume that that virus is not going to be replicating and shedding out of your body. If you're ill and you've been diagnosed with COVID, you need to stay isolated for 10 days from the first day you're sick until 10 days has gone by and you no longer have fevers for 24 hours and you feel better overall. Now, this is a great opportunity to talk to people because there's a lot of confusion about being infectious and being sick. And we know that infectious period of COVID is from 2 days or 48 hours before you even show any symptoms to the first couple of days of symptoms. That's when you shed the virus most. And then again, it slowly decreases until we were pretty confident at 10 days that you wouldn't be shedding any virus. Most people still feel, well, if you're going to feel sick from COVID, it's quite likely you may not feel completely better over 10 days. And that is not because the virus is still shedding. This virus has a unique way of impacting our system and creating inflammatory responses where many people feel ill, fatigued for longer periods of time. But the fever should be gone, and the fever generally indicates ongoing viral replication. So as long as you have a fever, you have to remain isolated, and you have to remain isolated till that fever has been gone at least 24 hours. But most people feel much, they're better at that beginning, but they continue to feel this lag, ucky feeling way out into that 1, 2, 3 week range. And that's a little different than actually still being infectious. So talk to your doctor, make sure that you understand those parameters. And one is set so you don't infect other people. But the other thing of feeling ill obviously has a lot more impact on how you're doing and how you're functioning.
Okay, along the same line, somebody just wrote this question. Can a positive case come out of isolation and quarantine if they have not had symptoms in days, but they keep testing positive and it has been 14 days?
Okay, so isolation's when you're sick, and that would include when you have a positive test and don't feel ill. So isolation is when you're infected and you know you're infected. That's 10 days. If you don't have any symptoms, you still need to wait 10 days from the day you had the test. And we don't use repeat testing to indicate when a person is no longer infectious, because some of these tests can remain positive in some individuals for very long periods of time, well beyond what we know that are still infectious. So you might remember at the beginning of all this, we were recommending repeat testing and 2 negative tests in 24 hours. And it was not working out really well because there is a certain percentage of individuals that would keep testing positive. And they're not still infectious and they're not getting reinfected. So we use the clinical 10-day rule to recommend when people can get back into the workforce or get back into doing what they want to do. 14 days quarantine is when you've been exposed, and we don't want you to start developing infectious capabilities. Remember, I said you can be infectious 2 days before you're even sick. So we want you to stay quarantined or excluded from other people for 14 days. And if you're not sick at the end of those 14 days, you don't need to do anything else either. You can just start moving around again. Now, if you get sick during that 14-day quarantine, then we certainly recommend you get tested to see if that illness is related to COVID or maybe to something else. So, and if you test positive at that point, then you go into isolation. Then you go into the 10-day range where you have to stay home from the day you get sick, 10 days until we know you're no longer infectious. And there's a great flow chart on our website that walks through this. What do I do if I test positive? What if I do if I've been exposed? And you can walk through that or send us some questions. We're more than happy to walk through that with you as well.
Okay, next question. When will our county hospitals have access to Regen CoV2? Regen.
Okay, so that's one of the newer monoclonal antibodies was submitted for EUA. Was it approved, Justin, for EUA?
It does have an EUA.
Okay. So they will have access to it when they have access to it. These medications often, even with emergency use authorization, don't have a high capability of being manufactured in a high volume, especially monoclonal antibodies. They're very unique medicines that require pretty meticulous manufacturing. So they're generally released based on availability. And given that they're a more scarce resource, the federal government and the state governments will generally distribute them based on a need. Okay? It's not like our hospitals can just go and order these from a pharmaceutical company. When they're emergency use authorization, they're just still kind of controlled by as being a scarce resource and by who needs them most.
Yeah, and if I could jump in too, the way that works, like in every state, but especially in ours, is it would go to the hotspots in a state or in an area of the country. And even though we have a fairly high % positive, there are areas of the state and the country that are much higher and, may need those resources more to facilitate some healing. So I would expect that as it becomes more readily available, we may have it, but we may not yet.
Yeah, and it's more complicated than just the amount of positivity, right? It's also about the capacity of the hospital systems. For instance, in our northern areas of Michigan, they generally don't have the robust hospital capacity that we do in southeastern Michigan and even on the west side of the state. And so they're struggling more, and they may need more support with those resources. On the other hand, they could start just kind of transferring people to tertiary care hospitals where we focus and concentrate these special resources in one place, and then bring the people there that need it most. So I don't think this has been really worked out exactly. In fact, I know it's not been worked out specifically in our state. So as we learn more, we'll certainly share that with you.
Okay.
That's going to work.
Next question is, someone wants to know if you've tested positive for the virus, but you are asymptomatic, can you still pass it to others?
Well, of course. Of course. So a fairly large percentage, that's why this infection has been so difficult to control, is because people shed it when they're not having any symptoms and before they have symptoms. And we feel that there's a fairly substantial amount of people who never report symptoms, as much as 35 to 40%. And Brandon, we've looked at that question ourselves in our own data. Wasn't it 17% of all of our cases were asymptomatic? Okay, about 15 to 20% in that range, which means it's a little bit lost on the national data that we're seeing. Kind of, I think, depends on what communities you sample and how you do that sampling. But there is no question that you can shed this infection and not know it. There is also no question that children can shed this infection and not know it. There was a little question at the beginning whether kids can even get infected, and if they do, if they can even share it. And they can. They do get infected, and they do shed the virus and infect other people. They're not necessarily super spreaders or worse than anyone else, but they're not an exempt population.
All right, this next question is kind of long, but it's about wondering about our statistics. So this person asked or stated that the case numbers for last week that were shown at the beginning of the Facebook Live don't match what has been posted on the dashboard daily. The prior 7-day period, including today, had a total of 821 new cases for a 7-day average of 117 cases per day. Can you comment on whether the dashboard data is wrong, or is there a screw up in the results shared in the video? Now, a long one.
So it's just when the data is pulled. I've tried to explain this to you guys many times. Data is data. It is not a one-to-one reflection of every case that's in the county. We know that we miss a lot of cases. We know that some cases go to the wrong place, get put on our dashboard, and then have to get pulled off because we find they're from some other place. People get shifted all the time. And so the idea is not to provide you an absolute accurate number. There are 241 cases, and it's more to show you trends and direction of the infection. So it really depends on when the data is pulled. Some data dashboards the state is using are a week behind. Some are 2 to 3 days behind. We try and keep ours updated, but I'd still say we're still probably 48 hours behind. Well, I'd say, yeah, about 48 hours behind what actually comes in real time. So what my staff is actually dealing with is different than what we post. So please don't get hung up on the actual integers, the actual numbers. Please follow the trends, follow kind of the percentages. Proportions, I think, are really helpful here, because we know what the denominator, we know what the population is that we're concerned about, and we have a general idea what the impact or the penetration of the disease or the event that we're measuring is. And based on that, we'll give you proportions or percentages. And those change as well, but those changes, I think, are a better reflection of where we're going up or down or staying the same. If you're trying to go by 1 or 2 numbers or even 10 numbers, you're just going to drive yourself crazy, because it's going to fluctuate all the time. That's the way data is, especially real-time data, which takes most researchers months to wipe, to sweep, and to clean up before they present it in a research paper. So that's not what we're providing you. We're not providing you end result data. We're trying to provide you real-time data to give you an idea of what's happening in our community. So I hope that helps.
And to add to that too, right? If we have 817 or 847 or 797, that again, that's not the point. The point is we're trying to just show, as Doc said, the trend lines up and down and how the community is reacting throughout the event. So it's more just a better understanding of where we are.
Thank you. Okay, if you're in a household where someone tested positive but is isolated, should the others living in the house also be tested?
Though the rest, if you're living in a household that has a positive individual, you are all by definition now in quarantine. You've all been exposed. I mean, unless there's some very specific living arrangements where that individual lives in the trailer outside or something different like that. But generally, if you're in a household with a positive individual, you have been exposed, and you should now not go out and do things for that 14-day period, as I discussed earlier, from the last day you've been exposed. So if you continue to live with that person who is sick or is positive, remember I said that they are contagious theoretically for 10 days. So your first day of quarantine would be your last day of exposure, which could be the 10 days after they've been diagnosed. So that gets a little tricky. But I think the other question was, should you all get tested? And the answer to that is maybe. So what you shouldn't do is all run out and get tested the first day you identify that you've been exposed, because it takes your body, if that virus has entered your body and is replicating, it generally takes our testing, the test that we have and the sensitivity it has, it would take about, well, first of all, it takes the virus 2 or 3 days to even replicate in enough amount to even identify it. And most people won't even become infectious until day 3 to day 5 or 6 at the earliest. So your best bet is to stay quarantined, because I mentioned a negative test doesn't get you out of quarantine, and then to get tested if you feel sick, because then that illness can be identified as either another COVID case, or maybe you've just got some food poisoning or something else going on. So if you do get tested and it's negative, you're not out of quarantine. And if you do decide to go get tested, try and do it kind of more in the middle to end range of your quarantine period, because then it'll be a little more likely to be a reflection of what's going on. But remember, a negative test on day 12 does not negate your quarantine period, because some people will still convert on day 13 or 14. Okay?
Okay. Last week, we put out a new map during our weekly Friday update, and somebody wants to know, are there certain areas that are hot spots?
What do you think?
Everywhere.
It is everywhere. About a week ago, I would have been looking at some of our townships out on the west side of the county. But if you look at it now, it's pretty diffuse. There's a lot of virus out there, a lot of virus, and there's a lot of people walking around with the virus that don't know it. I'm assuming that nobody who's sick would willingly go out and expose themselves to other people. So let's just take that off the table. But the problem is, as I mentioned, this virus is spread very easily before you're sick, or maybe you're not going to get sick at all. And there's a lot of it out there. Your chance of being exposed to this virus now, going anywhere outside your home without really rigid adherence to the masking and the 6-foot distancing, I would say is pretty good. It's I would say more than 15 or 16%, right? So, 20%, figure that out, 2 out of 10.
Okay.
So
Someone wants to know, when they get an antibody test, does it check for COVID or just if you have the antibodies for COVID?
No, antibody tests will only check for antibodies to COVID. Most of them are very specific for the COVID, the SARS-CoV-2 the one that's causing COVID-19. The problem with some of those antibody tests is they weren't as specific. We have 10 coronaviruses that cause human disease, and 4 of them cause common colds, and very likely could be circulating even now. So one of the problems with those antibody tests, if they're not specific for the SARS-CoV-2 virus, they may pick up other coronaviruses in your system, or maybe something that you had a few months ago. And that is, of course, there's so many antibody tests out there. Your best bet is to go to the FDA website and see what your antibody test, who is manufactured by, and whether or not it's approved or not approved. But we have a hard time keeping up with it too. I would still not recommend antibody testing for anyone if they're trying to use it as a guide to what to do clinically. Okay. And when I say clinically, I mean what to do with your personal well-being and your personal health, whether you should isolate or quarantine, because a negative antibody testing is not particularly reassuring. We don't know how sensitive or specific these tests are. And if it's positive, it doesn't mean that you're immune. Although if it is positive, with some of these specific tests, as I mentioned, you may assume that you had the virus in the past, but it doesn't really tell you what that means. So my recommendation is to get a molecular test, which is the swab in your nose, or an antigen test, which is also a swab in the nose. Okay, if they're doing your blood from a fingertip, it's probably an antibody test, and we would not want to use those to identify you as somebody who is sick or not, or has the virus or not. You want to use the other 2 tests.
Okay, the next question is about elementary schools. So this person is asking, why are we sending our elementary students to school when they can bring it home and spread it to parents, family, and teachers?
I want to give Justin a chance. Risk benefit. You want to go into the risk benefit thing?
Yeah. So right now, the data that we've been shown and that's being shown around the state shows that K through 5 is the students that are least being impacted by the virus. And what schools that are going back are doing, they're gathering all of their teacher resources and focusing them on the K through 5 or K through 6, whatever your younger grades are, your primary grades are. So that's why the governor through MDHHS put the rule out to close high schools, but gave everybody the option to keep primary schools and middle schools open. So it falls back to, can the school districts staff the schools? And if that answer is yes, they can safely staff the schools, then it's up to the district to make those decisions with input from the health department.
So it also kind of is a reflection of essential services, right? So we know that bars and restaurants, indoor dining, indoor gathering, in fact, seems to be a big driver of transmission. So we look at what's the risk of close. I mean, there's risks to everything, right? I mean, my heart breaks for some of these private business owners that are struggling so hard. But we know, for instance, we're keeping a lot of businesses open despite the fact that they have cases, because what they do is essential for the well-being of our society and our community, right? We have to still function. And we consider schools in that realm of highly important gatherings. It's important for our kids to get an education. This could go on for a really long time. We're hoping not. We're hoping that there's an end in sight. But I mean, really, we're going to be dealing with this virus for a long time. So learning how, if you will, to live with this and figuring this out as we go, and knowing that K through 5, K through 6th grade is a fairly low risk environment. Now, not to say they're teachers now, but your teachers can protect themselves again. Remember, masks and social distancing really, really work. And our schools are doing a great job in supporting that. And we're going to continue to support them with other means if we can. So if we can create a low risk environment and the value of that environment is very high, then we want to continue to try and do it. High schools, on the other hand, they were harder to control, that population. They just had a higher rate of transmission. and it was harder to keep them in small little cohorted groups. And I think that's one of the reasons why they differentiated the high schoolers from the grade schoolers. Plus, high schools are older and they do have more risk with infection. So I hope that helped.
Okay. Speaking of masks, someone last night submitted a question asking if you could please reiterate people properly wearing masks, because it does no good when their nose is exposed or their mask is hanging around their neck.
Pretty simple.
Yeah.
So we breathe through both. Got to cover both.
Yeah. Yeah. If you're covering just your mouth.
The virus enters and leaves our body attached to respiratory droplets that are released in our nose and our mouth. And most of us breathe through both. So if you are only covering one, there's still stuff coming out of the other, and vice versa coming in through the other. So in order to protect yourself and protect other people, you really need to cover both orifices, right? It's just the way it is.
Okay, I'm going to kind of summarize this next person's question because they had a lot of comment in one section. But this person says, it seems to me we need a test that helps detect when someone is infectious. Why haven't we put more effort into the paper test, which Dr. Mina, M-I-N-A, a Harvard epidemiologist, has been discussing as early as June? Do you know anything about that?
Paper test. Well, so our antigen tests look like paper. They're on a flow, kind of like a pregnancy test, where you put the sample in a solution and it goes up and it gives you 1 line if it's negative and 2 lines if it's positive. So we do have those tests. I don't know if that's what you're talking about. I'm sure we're going to see more tests as time goes by. And I'm not an expert on why tests get manufactured and when they get released. I just know that even now, tests are still a finite resource. It's not like we can get online and just order them. So the whole world wants testing and the whole country wants testing, and we're going to have to do our best with what we have and what we can get. And we have a resource procurement expert here with Mr. Westmiller. Him and his team are phenomenal when it comes to finding resources. I couldn't have a better partner in this. So I rest assured we're doing everything we can to make sure we get the resources we want and need and think we might need. We've been trying to be proactive with this as well. It's just not as easy as it looks.
So Doc and Justin, again, after the show, maybe you can go back through the questions and look at this person's particular comment.
Yeah, I'd be happy to. In fact, I'll look it up for him and see if I have any further insight on that test. Doesn't ring any bells, but okay. I'm just trying to keep up with published papers, let alone non-peer reviewed. So
if I can just interject too. Yeah, if I can just interject too. Again, if those types of tests are out there, if they're not readily available in large lots, it would still be fairly difficult to get them all the way to St. Clair County. I mean, we have less than 160,000 people that live here. We are doing fairly well, not great. We know that we're seeing more disease than we ever have, but there are places that are much, much higher, and any of those brand new resources would go to those hotspots. Even though we're top 10 as far as spots in Michigan.
And don't forget, just because it's brand new doesn't mean it's better. I mean, we've been through this game already with hydroxychloroquine and with convalescent plasma. So we got to be careful not to jump and get all our, put all our eggs in a basket. I mean, we have finite resources. We want to make sure that we use them wisely. So that's what we have a team for. It's not just me deciding or Justin deciding. We have a group of experts. We meet all the time and try and figure out what is the best direction we have on what we can get and what we should get. And I'll be honest with you, it's been changing since this thing started. So we'll continue to watch for that.
Okay. You already answered this once, but this person answered this maybe after they came on. But what is the average age of deaths? how are our hospitals doing, and that this person has some nurse friends that state that they have 0 ventilators available.
Well, I can, so the average death age is 73, but the range is 30 to 90. So our death range is across the board. 5% of those deaths have no pre-existing condition. So, we do know that really technically anyone is at risk for severe illness and death, but the older you get and the more diseases you have, the greater your risk. But that's a lot of people in our community. Okay. So our hospitals are not at full capacity. They're all reporting less than 100% capacity, less than 90% capacity, all of them, some more than others. And they're reporting they're busy, but none of them have extinguished all of their ventilators. They all have ventilators. They're all reporting that they have. No?
No, you're right. That's what I'm saying. So,
no, we just talked to them today, and none of them are reporting
Yeah.
that. They're all reporting they still have ventilators available. In addition, we have ventilators available for our region. We have shared distribution, talking
more than
with people.
150.
Yeah, so there's room here, not for us to explode indefinitely, but if we can pull this in and keep this together, I'm still up, like I said, cautiously optimistic that we can pull this off. And our hospitals all have really good plans about expanding their COVID capacity as well. And they're not there yet. They can all expand and create more wings and beds and things available to support this. And remember also, we are not ventilating nearly the same amount of people. We've learned a lot from that first wave in the spring, and we know now that we don't have to ventilate everybody that drops down into the 80% range or whatever those indicators that would be normally. They're doing well without ventilation, most of them. So you're also not seeing this kind of rapid escalation of ventilators either, which is a good sign.
Yeah, and if I can speak to that too, we have 40 plus ventilators in the county, and then all the hospitals can turn some of their sedation equipment into additional ventilators. So we have not reached the limit at all by any means.
Okay, this person had asked the earlier questioning about our data, and they're saying that usually the weekly numbers match exactly what's on the county dashboard, but this week their numbers are off by over 100 cases, but the cumulative total of 3,901 are the same. Is our math correct?
Well, I'll tell you what, we'll go back. I'm looking at my data analyst right now. We'll go back and we'll recheck things and get things caught up. It's been a busy week. What did you have to say? Yes, that is true. And that is the other point. We normally update everything and really cross our T's and dot our I's on Thursdays to do this. So we're a couple days early, but we will go back and review that for you and for everyone and make sure that we get it as accurate as possible.
Okay, thank you.
Thanks for watching.
Question. The CDC put out information on the shielding approach and green zones the other day. Can you elaborate on how that would look?
No.
We'd have to look into it.
I have to look into that. Let me look into this because no, sorry.
Okay.
It's been a very busy week just trying to plan on vaccine delivery and other things. I'll be honest, neither one of us, I don't think, by the look on Doc's faces, has heard of, I know being a former military officer, I know what the green zone means, but I'll have to look into it. I can assume
what shielding means, but yeah, let's, source control. They keep switching with different terminology. Let me get back to you. We'll go over this next Tuesday for sure. And maybe I can respond to that email or that question directly.
Okay. The next question is why are kids allowed back at school while waiting for COVID test? Why isn't the health department informing schools when a child is tested, not just positive?
You probably don't know. To be honest with you, we probably don't know who's getting tested and who's waiting, who's not waiting. We rely on the schools to tell us who's positive. And we rely on the schools to tell us from those positives who's been exposed. So the closest we get, usually if we have a confirmed positive in a household, usually a parent, and then we can, kind of confirm the quarantine status of the whole household. But I've said this before, my staff and the staff of, I would say, virtually every health department, local health department in the country is not keeping up with positive cases and who's tested and who's not tested. And you people have to do this yourself. You know how to do it. We've gone over it a million times. There's stuff on our website to review it. If you're waiting for a test result, you shouldn't be bouncing around, because if it's positive, you've just exposed a bunch of people during that time frame. So you should be waiting for your results before you send your kids to school, and you should be waiting for your results before you go to work, and you shouldn't be doing either if you're still sick. Okay.
Yeah, quick PSA for all the parents. This year is not like every other year. If your children are sick, please, please, please do not send them in a congregate setting like a school. This is the worst time ever to do that. So we're begging you not to do that. If you have gotten a test, keep that child home, period.
Do we want to segue a little bit? When you kind of alluded to the fact that we've been really busy this week vaccine planning. Do we want to spend a few minutes just talking about vaccines before we sign off? Are there any specific questions, Jen, about vaccines, or should we just jump into it?
Well, we had one that, when will a vaccine be here? When it arrives, will it be safe?
So we expect our first vaccine shipment, which will probably be the Pfizer ultra code shipment requirement, probably in December. I would say in the mid-December range. It's still not clear. We get it when the state gets it, and that'll get pushed out. So it's a challenging vaccine in the sense that it has to be kept at an ultra cold temperature for it to be viable. It's going to require a lot of logistic planning, and that first shipment is going to go primarily to the people who are taking care of COVID patients, the people who are directly trying to keep people well and not to die. Okay, let's say they're the people in the trenches. That's our first focus. With that, as soon as we can, we're gonna pivot and start vaccinating other first responders, our essential workers, people that need to be out there as well, in the trenches in a different way. So this is going to start rolling out, and it's going to be coming on an ongoing basis. Is it safe? So far, the manufacturing data is very reassuring. Put it this way, the phase 1 trials, the phase 2 trials, and the phase 3 trials have not been compromised, and they would not get approved by the ACIP, which is the Advisory Committee of Immunization Practices, unless that safety data was carefully reviewed, and they're an independent group that does this. So if the ACIP tells us that all safety measures have been passed and they're okay for us to use it and what the recommendations are for use it, I can't do any better than that. It will take millions of vaccines to detect very, very rare side effects, but the clinical trials, the phase 3 trials, have been done on tens of thousands of people, and we have to trust that that would have revealed the majority of serious side effects, certainly any critical ones. As you know, a couple of vaccine manufacturers have stalled, paused, and restarted because of these signals. And the only other thing I can say is that so far, the vaccine that's coming out, these initial mRNA vaccines, which are unique and really quite wonderful, in fact, they are very immunogenic, which means they're along the lines of like our Shingrix vaccine, which can cause a fair amount of local arm tenderness, muscle pain, maybe some low-grade fevers and fatigue. This isn't the virus in our bodies. This is our immune system reacting to a very potent vaccine. And so we want to warn people ahead of time. We'll talk a lot more about this as it rolls out to those of you as you become in that category where it becomes available to you. But you can expect this vaccine to make you feel a little achy. Now, the Shingrix is like that. I got both of mine and I was great. Not everybody's going to have this, but it is a vaccine that causes these kinds of local problems that is not the same as a serious event, okay, as far as some other serious. And that's not surprising because we know vaccine development has looked at this for a long time. And vaccines, as a rule, do not cause serious events. They can cause serious adverse kind of things with arms, etc. The definition of serious in some situations is where it interferes with your normal ability to function. So a sore arm, muscle aches can make it a little hard for a couple of days to feel Johnny on the spot. But that's what we know about the vaccine so far. And as we learn more, we will share everything we know with you. There will be no secrets about this vaccine. We're going to be completely transparent. So you can make your decision to vaccinate or not based on the fullest amount of information available.
Okay, so it's almost 4:15. We have a few more questions, or we can save these questions for next Tuesday. What would you like to do?
I'm good.
Let's go.
Stay. Go? Okay.
Go.
All right, ready? Next question. With the deer hunters returning for Thanksgiving, what precautions need to be taken in the home?
I can take this one. So
Go.
if you've been in a congregate setting with other people outside of your family, you should take the time to isolate yourself, or quarantine yourself, up to 14 days to ensure that you either weren't infected by somebody who didn't know about it, or you don't affect others in your family. That's the safest thing to do. Remember, distance is always your friend in this COVID response and dealing with this disease. So if you have any family interaction, stay masked, wash your hands often.
Try and do as much
away
as you can outside. Mm-hmm.
Yeah.
And be conscientious of those people in your family, your loved ones, friends, neighbors who are particularly vulnerable as well. So, I know when we were planning Thanksgiving with my one and only son, who is the apple of my eye, we both decided that we weren't going to do anything. Either one of our households are going to do anything for 14 days before we got together. Now, we've canceled that. We are not going to get together anyways because it's the right thing to do. He's in a different state, and we're telling people that. So it's heartbreaking not to be with the people you love. But that idea of making sure that you've protected yourself before and after an exposure, potential exposure, is very helpful. It's a pain, but it is the way that you can protect particularly people who are really vulnerable.
Okay, next question. What types of activities do you see causing most of the infections in our county?
Well, all infections in our county are from person to person, we're assuming, okay? I mean, I guess there's still that potential of getting an infection from a surface, but the assumption that we're seeing from all of our scientific entities, it's still person-to-person transmission. So all infections are from that person-to-person transmission. Sometimes we don't know. You'll ask people and they'll say, we have no idea where, but they were out and about. There's been some studies that show, again, indoor dining, bars are a notorious, I think 2 to 3 times higher rates of people that frequent, bars and restaurants get infected. But we also know a lot of people are getting infected from merging households, from gatherings, going to parties. I mean, it's really across the board. And work environments, let's face it, right? Work environments, if you're not really super careful, you're exposed to people in your workplace. So all of the above.
Okay. Next question. Are you seeing the same symptomology with COVID as previously in the year? Cough, fever, shortness of breath? Are most of the hospitalizations due to issues with oxygenation? Excuse me, I can't pronounce that. Not sure if you're able to answer this, but I thought I'd ask.
Well, we could look, I have to say, it would be helpful to look at hospitalization data, and they are too busy really to do that for us right now. But my understanding is the major reason a person gets hospitalized is because they can't breathe or they're breathing poorly. So oxygenation, breathing too fast, their heart rate is going too fast, signs and symptoms that would suggest the body is struggling very hard to oxygenate. So that would be the main COVID-related reason. But remember, comorbidities can also be made worse by infections, COVID infections and other infections. So renal failure might get worse. Heart disease might get worse. There are other medical reasons that can be worse, that require hospitalization, that are just kind of exacerbated by the COVID infection. So it can be across the board.
Okay.
But most, I think, are from oxygenation levels, yes.
Do you see this pause actually ending on December 8th?
No. Sorry. No, I've said this before. So if we see positive data trends at the end of this 3-week period, I can't imagine saying, okay, never mind. Let's just forget about it. I just can't imagine, because let's face it, our hospitals are going to continue to show really significant concerns, and our death rates are still going to be going up. Those lag behind increased cases, and our cases are still going up. So even if we see new cases slow down a little, we're going to continue to see this increased trajectory of hospitalizations and deaths, which is not the time we're going to be going, okay, never mind, let's just go back to normal. So I don't know exactly how we'll respond, but I'm hoping with positive trends, we can just kind of stay the course. And of course, with negative trends, we have to ask ourselves, what can or should we do beyond what we're already doing? That would be my guess.
Next question. Do employers have to announce that they have employees that tested positive?
They do not have to announce it. They have to notify the employers who've been exposed. Okay. And they have to report to us positive cases within 24 hours. They do not have to publicly announce to every employer that they've had a positive case in their building. No, but they do have to tell all the people who've been exposed that they've been exposed.
Okay. This next person states that they were exposed to a positive COVID case November 13th. November 18th, the husband tested positive. The wife tested negative November 14th. Then tested positive at Kroger for IgG, but not for IgM. Why can I not assume I have had COVID?
Why can you not assume? Because I just said those antibody tests are very unreliable. I don't know what kind of antibody you test. I don't know if it's specific to SARS-CoV-2. And IgG is a more of a chronic phase. It could have been an infection a long time ago. It's just not a reliable indicator. I would rely on how she's feeling. If she was exposed on the 13th, I would recommend that she stays quarantined for the 14 days from her last day of exposure. If her husband was diagnosed on the 15th, she needs to quarantine from then on, not from, it's from the last day of a known exposure, and do the quarantine right. And if she's still not ill at the end of the 14 days, carry on. That's how I would approach it.
Okay, we have a few more questions left, and then we'll end.
Thank you.
Will you mandate healthcare professionals to get the vaccine when it comes out?
At this point, I would have to say no. Mandating a brand new vaccine in the middle of a pandemic is probably not the smartest thing to do. I think we have to use the vaccine smartly. We have to watch and make sure it's doing what we think we want it to do. We want people to do the right thing. Mandating vaccines is not the American way. We don't mandate any vaccines, right? Well, influenza in some situations. But the other thing, remember, is this vaccine has been issued under emergency use authorization, and no one's going to mandate a non-licensed product. That just wouldn't fly. So for a lot of reasons, I'd say no, not in the immediate future that I can foresee.
A couple questions about the vaccine. With the vaccine, are we testing for antibodies first? If I have COVID, should I have antibodies or T cells? Why should I get the vaccine if I've already had the virus? Does the vaccine produce antibodies or T cell response?
So the antibody does appear to produce both neutralizing antibodies and cellular immunity. That's a very positive thing, because we think that might make it even more effective, perhaps, than even a natural infection. A lot more to learn. We are not going to pre-test people for previous infection. We don't pre-test people for flu before we give them a flu shot. It's an added level of uncertainty, expense, cost, pain, and the approach will be just to vaccinate anyone who wants a vaccine once it's available.
Even if they've had COVID before?
Yes.
Yeah,
Yes.
because what we've learned is there's reinfectivity, right? So that's one reason why.
And we also have learned that people say they have COVID, maybe they haven't, or they don't know that they had COVID. So there's all kinds of variables on that. And the bottom line is it won't hurt to get a vaccine if you've already had the condition. In any of vaccine preventable illnesses, it doesn't hurt you to get a vaccine, even though you've had the infection previously. There's no counterpoint to that. And we don't know how long immunity, even from a natural infection, will last. So giving extra protection is just a win-win. There's no downside to that we know of.
Okay. And if someone was around a person 3 days before a positive COVID test, should they be tested?
3 days, we say 2 days. Again, I'm not telling people to rush off and get tested the minute you know you've had an exposure, but I would be very careful. What's the difference between 48 hours and 36 hours? Depends on how infectious, but I'd be careful. I would be careful in this situation. I would be careful not to go around vulnerable people. I would be very careful to wear my mask all the time. I'd be very careful to stay 6 feet away from anybody else. And then if I develop symptoms, I would be quick to get a test.
Okay, we've almost ran an hour. We have one last question and then we can sign off.
Get one to Justin.
Well, Justin, maybe you can answer this one. When the health department says 3 to 5 days for results, is that business days or actual days? That's the last question.
Usually that's business days because the labs only work 5 days a week, right? So the labs, the commercial labs are not working over the weekend. So you could expect that it's business days.
Okay, so we will return next Tuesday, same time. And normally the show's a half an hour, but we try to get everybody's questions.
It hasn't been a half an hour for 2 months now. Maybe we can plan on being here for the full hour and do it. Seriously.
All right. Well, what are our closing comments?
Happy Thanksgiving, everyone. Be thankful, be mindful. This is a big sacrifice, but it's also, remember, it's temporary. What we're going through right now is temporary. And these small sacrifices, they seem big, but the long-term gain is huge and it's worth it. So stay the course, support each other, love each other, and raise a glass for me and my son who aren't going to be together. I love you, Tony. Justin?
Yeah, so happy Thanksgiving, everybody. I kind of will double down on, it feels like it's been forever, but as we look back on it, as a friend of mine said today, it will only be a blip in our lifetimes. I just need everybody to hang in there, keep hanging in there. And I appreciate everything that everybody's doing to keep your community safe. And we'll see you next week.
Happy Thanksgiving, everyone.